Salam alaikum.
Assalamu alaikum.
Hi, everyone. Salam alaikum. Uh, welcome to the Zoom meeting. And we're gonna start the meeting in a minute. I just want to wish you all the best and happy Eid to all. So without ado, Dr. Maisam and her team will be leading today's meeting. Thank you. I'm gonna hand it to you, Dr. Maisam.
Thank you.
Assalamu alaikum. Eid Mubarak, everyone. I hope you all had a lovely Eid and you got to enjoy your, spend some quality time with your family and friends. So today we will be having 3 presentations, inshallah. The first one's going to be schizophrenia spectrum and other psychotic disorders. This will be presented by Dr. Mohammed. And then we will have polypharmacy in older adults. This will be presented by Dr. Monia and Dr. Bushra. And then finally, selection bias by Dr. Nidhal. We will leave some time at the end of each presentation for your questions. And at the end, we'll spare some time as well for any project updates and any concerns. So Dr. Mohammed, you can start sharing your screen and presenting your presentation.
Okay, thank you. First of all, I want to say Assalamu alaikum. Eid Mubarak to all of you fellows, and for you specifically, Dr. Nadir, may Allah bless you and your family. Can you please confirm whether you can see my screen or not?
Yes, we can see your screen.
Okay, thank you. Okay, so regarding schizophrenia spectrum and other psychotic disorders, this will be the topic that we are going to discuss. Okay, so after this lecture, we are going to be able, inshallah, to describe how to evaluate a person with psychotic symptoms, the epidemiology and clinical characteristics of late onset schizophrenia, and how to evaluate psychotic symptoms associated with disorders other than schizophrenia, and how to manage older adults patients with psychotic symptoms. Okay. So topics to be covered: schizophrenia and schizophrenia spectrum syndromes, psychotic symptoms in delirium and delusional disorder, psychotic symptoms in mood disorder, psychotic symptoms in dementia. Also, we are going to talk about isolated suspiciousness and syndromes of isolated hallucinations, which is known as Charles-Bonnet syndrome. Other psychotic disorders also, like psychotic disorder due to another medical condition, like substance or medication-induced psychotic disorder. Okay, what about psychotic symptoms? As you know, doctors, there are like a lot of psychotic features or symptoms, such as hallucinations, delusions, disorganized thought or speech. Regarding hallucinations, hallucinations are perceptions without a physical stimulus that can affect any of the 5 sensory modalities: auditory hallucination, visual, tactile, olfactory, and gustatory. Okay. Regarding for delusions, delusions are fixed, false, idiosyncratic beliefs that can be of suspicious nature: paranoid delusions, grandiose delusions, somatic, self-blaming, and hopeless delusions. Okay, how to evaluate a person with psychotic symptoms? First of all, you need to evaluate the underlying causes such as delirium, dementia, stroke, Parkinson's disease, or substance abuse disorders. Acute onset of altered level of consciousness or acute onset of confusion or inability to sustain attention suggest delirium. So doctors, delirium is acute confusional state. Delirium most often superimposed on an underlying dementia is the most common cause of new onset psychosis in late life. Next, we need also to consider a primary mood disorder when evaluating a patient with psychotic symptom. Only after other causes are excluded should the diagnosis of schizophrenia spectrum disorder be made. Okay, let us talk about schizophrenia. Schizophrenia, doctors, as you know, it is a chronic psychotic disorder characterized by positive and negative symptoms, usually beginning in the late teens or 20s. Examples of positive symptoms: hallucinations, delusions, and thought disorder. Examples of negative symptoms like social withdrawal and apathy. As I said, we have to exclude mood disorder and cognitive disorder to make the diagnosis of schizophrenia. Okay, there is also what is known as schizophrenia-like syndrome of late life, or late onset schizophrenia. Onset after the age of 40, the incidence is higher in female. As you can see, female to male ratio range from 5 to 1 and 10 to 1. Prominent persecutory or paranoid delusions and multimodal hallucinations. So this is a type of delusions which tend to occur in late onset schizophrenia. Differences from early onset schizophrenia: late onset schizophrenia characterized by much lower incidence of thought disorder, and personality and social functioning are often better preserved than early onset schizophrenia. Again, regarding the thought disorder, as you can see, it presents in about 5% of late onset schizophrenia. However, it presents in about 50% of cases of early onset schizophrenia. If we are going to define the thought disorder, doctors, thought disorder or speech disorder, it is the same thing. Speech or thought in which the thought or the speech are not connected to one another in a logical fashion. That is what we mean by saying thought disorder. When illogical speech occur in late life, delirium or dementia should be excluded. Okay, what are the clinical features of late onset schizophrenia? Again, unlike individuals with early onset schizophrenia, many people with late onset schizophrenia, like psychosis, have been able to hold responsible jobs, marry, and or have long-term relationships. So as we said, their personality and their functioning is preserved, not like early onset schizophrenia. But premorbid symptoms are common in late onset, okay, like isolation and schizoid traits, social isolated personalities. Okay, what about the non-pharmacological treatment of late onset schizophrenia? First of all, doctors, you need to establish a trusting therapeutic relationship, therapeutic alliance with the patient. Empathize with distress caused by symptoms. Also, we have to encourage patient to maintain important relationships. And we can also ask permission to discuss source of symptoms with close family members or friends. Regarding the pharmacological treatment of late onset schizophrenia, antipsychotic drugs are as effective in late onset schizophrenia as in early onset cases. We can increase the dose of the antipsychotic drug semi-weekly or weekly as needed. Antipsychotic responders should continue for at least 6 months. For patients who relapse on treatment or when the dose is lowered, we have to maintain the treatment for at least 1 to 2 years. Also, we are going to monitor for extrapyramidal side effects such as Parkinsonian tremors, dystonia, and rigidity. Not to forget that we need to avoid polypharmacy in such case by reducing or switching medication rather than adding a medication for extrapyramidal side effect. Because as you know, doctors, extrapyramidal side effect, it is one of the most common side effect of antipsychotic, typically the first class. And also, we should consider concomitant anticholinergic medications. Okay, for commonly used antipsychotic medications, we have like two tables. Here we are having the agent, the starting dose, the maximum dose, and the side effect associated with each drug. As you can see, doctor, these are the different side effects: extrapyramidal side effect, drowsiness, and weight gain. And here we are having the agents. 1 indicate that the side effect is uncommon. 3 indicate that the side effect is common. As you can see, doctor, for extrapyramidal side effect, it is more common with haloperidol or first generation antipsychotic. To be more precise, the high potency first generation antipsychotic associated with the most cases of extrapyramidal side effect. For drowsiness for drowsiness, it is associated with acinabine and clozapine. Also, weight gain or metabolic syndrome associated commonly with second generation antipsychotic like clozapine and, let us check here in the other table, olanzapine. Olanzapine and clozapine associated with the most cases of what? Of metabolic syndrome or weight gain. Here, as you can see, doctors, also quetiapine associated with drowsiness. So these are the common side effects for each antipsychotic drug. Okay, one of the most serious extrapyramidal side effects is tardive dyskinesia. Tardive dyskinesia, it is characterized by repetitive involuntary movements of the oral and limb musculature. Older age is a predisposing factor. When an antipsychotic is started or as soon as symptoms improve enough that the patient can understand the risk, we need to educate the patient about tardive dyskinesia and the possibility that it can be irreversible. In 2017, the FDA approved valbenazine, the first medication to treat tardive dyskinesia. Actually, also, in some cases, they switch different antipsychotic to clozapine in case this tardive dyskinesia occur. Okay. What about psychotic symptoms in delirium, in patients suffering from delirium? Hallucinations, particularly visual hallucinations, can be a symptom of delirium even when it is mild. Onset is usually acute. As we said before, doctors, the nature of delirium is acute confusion. And there is often an identifiable metabolic or infectious cause. Mental status examination in delirium will reveal multiple cognitive impairments, diminished or waxing and waning level of consciousness, and the hallmark is impaired attention and level of awareness. Okay. For psychotic symptoms in delusional disorder, doctors, as you know, it is a long-standing chronic delusions without hallucination. So patient will suffer from pure delusion, no hallucination. In patient with normal mood and no cognitive impairment. So everything is normal apart from what? Apart from the chronic delusion. It is more frequent among women, but more severe among men. Delusions are most commonly persecutory or paranoid, but can also be delusions of jealousy or somatic delusions. Management include reassurance, amelioration of sensory deficit, and sometimes antipsychotic medications. Okay. Psychotic symptoms in mood disorders. Here, doctors, delusions are mood congruent. So it will depend on the mood of the patient. If the patient mood is heightened or elevated, his delusions will be grandiose. If the patient's mood is low, like in depressed patient, the content of the delusions usually reflect extreme self-deprecation, self-blame, hopelessness, or the conviction of ill health. So, for psychotic symptoms in mood disorder, the delusions will be mood congruent. What about psychotic symptoms in dementia? Patients with dementia, doctors, will experience both hallucinations and delusions, usually less complex than delusions seen in schizophrenia or mood disorder. Common delusions in dementia: belief that one's belongings have been stolen, conviction that one is being persecuted, and belief that one's spouse is unfaithful. These are the common delusions in dementia. What about the management of psychotic symptoms in dementia patient? Okay, the use of antipsychotic in this setting warrants careful consideration of the risk and side effects. Non-pharmacological interventions, doctor, such as redirection, reassurance, should be tried first. However, if the patient is physically aggressive or severely distressed by the psychotic symptoms, then a trial of low-dose antipsychotic is warranted. All antipsychotic agents carry an FDA warning regarding increased all-cause mortality in patients with dementia. Please don't forget this point, doctors. Okay. What about psychotic disorder due to another medical condition? Delusions and hallucination without prominent cognitive impairment that are likely to be a direct result of another medical condition rather than due to a psychotic disorder. Okay, often occurs in patients with known brain disorders such as Parkinson's disease or stroke. So here we are talking about a psychotic disorder due to medical condition, not a psychotic. Okay. Exclude delirium due to the superimposed condition. Delusions and hallucinations may be secondary to anti-Parkinsonian agents, but some experiences visual hallucinations prior to the onset of any medication. Can any one of you doctors explain how anti-Parkinsonian agents will result in delusion and hallucination? What is that?
Hello.
Uh-huh.
So the thing is, the problem in Parkinson's disease is the deficiency in dopamine. So dopamine actually, it works on the D1, D2 receptors. So when it works on the D1 receptors, it would be producing the psychotic symptoms. So it would be a side effect, like it would treat the Parkinson by working on the D2 receptor, but at the same time, it's going to be working on the D1 receptor and producing side effects. Yeah.
Yes,
So
yes, good.
Yeah.
So we have to remember that most of the anti-Parkinsonian agents are dopamine agonists, right? And
yes, that's what I meant.
yes, and most of the positive psychotic symptoms in schizophrenia, it is due to the dopamine effect. That is why we are giving antipsychotic agent like antidopaminergic agent. So the anti-Parkinsonian agents will increase the dopamine, which will increase the positive symptoms like delusions and hallucinations. Okay. Judicious discontinuation or dosage reduction of non-essential anti-Parkinsonian medications often provides relief from psychotic symptoms, like here. Okay. The second slide for psychotic disorder due to a medical condition. We have to remember that first generation antipsychotics may worsen Parkinsonian symptoms, as you know, as a result of extrapyramidal side effect. Cautiously try an antipsychotic off-label if the patient experiences significant emotional distress, symptoms lead to dangerous or upsetting behavior. Also, we can consider pimavanserin for the treatment of psychosis in Parkinson's disease. We can consider this. Actually, also, doctor, we need also to balance between the control of the Parkinson disease features and between the side effect of the anti-Parkinsonian drug. Okay. Prominent visual hallucinations, often vivid and troubling, are the key diagnostic features of Lewy body dementia. Patients with Lewy body dementia have heightened sensitivity to antipsychotic medication, including worsening of extrapyramidal side effects. No trial data are available to guide drug choice. There are case reports of significant improvement with cholinesterase inhibitors. Non-pharmacological treatment also, doctor, like redirection, reassurance, explanation, can be done. Okay. Regarding psychotic disorders due to a substance or medication induced, drugs of abuse can cause persistent psychotic symptoms after the period of acute intoxication or withdrawal. So both of drug intoxication or withdrawal can result in psychosis or psychotic symptoms like alcohol, cannabis, and cocaine. Many classes of medication can cause hallucinations or delusions like beta blockers, interferon, cyclosporin, steroids, antiarrhythmics, antivirals, opioid, anticancerous, baclofen, and several others medication. Okay. Isolated suspiciousness. From its name, doctor, it looked like more benign condition. Here, suspiciousness is a personality trait common to all humans, but varying in its prominence. May become more common in those 65 years and more. Distinguished from psychotic disorder by the understandable nature of the ideas. For example, one's excessive worry about safety, or the absence of other psychotic symptoms. These are the key factors for distinguishing isolated suspiciousness from other psychotic disorder. Okay. Isolated hallucinations or Charles-Bonnet syndrome. The criteria of this syndrome are visual loss or any patient, typically elder patient with decreased vision. They will start to experience silent visual hallucinations. And the patient will have partially or fully intact insight. The patient is aware that the perceptions cannot be real, but still report that they appear absolutely real and vivid. And also, the patient will lack any evidence of brain disease or other psychiatric disorder. This Charles-Bonnet syndrome, doctors, affect about 10 to 13% of patients with bilateral acuity less than 20/60. So visual loss is a risk factor. What about the management of Charles-Bonnet syndrome? The best treatment is information and support. We have to reassure the patient that the hallucinations are a sign of eye disease, not mental illness. A few patients, doctors, have partial insight or lose insight and become very distressed by this symptom. When this distress is significant or leads to dangerous behavior, a cautious trial of low-dose atypical antipsychotic is occasionally beneficial. Okay. To summarize in 2 slides, psychotic symptoms are defined as either hallucinations or delusions. Psychosis occurring for the first time in late life is often due to a neurologic condition such as dementia or stroke. 10 to 15% of cases of schizophrenia first come to clinical attention after the age of 45. Okay, only after other medical and mood disorders are excluded should the diagnosis of schizophrenia like psychosis be made. Antipsychotics are as effective in late onset schizophrenia as in early onset cases. When psychotic symptoms arise in patients with depression or mania, the symptoms are mood congruent. Dementia with Lewy bodies is associated characteristically vivid visual hallucinations, often consisting of people or animals. Antipsychotics should be used quite cautiously in patients with dementia or Parkinson's disease. Because in dementia, as we say, doctor, antipsychotics will increase all-cause mortality. Okay, let us do a test. We are going to run on these cases and try to answer them. An 82-year-old man has become increasingly disruptive in the dining room at his nursing home. He accuses staff and other residents of conspiring to poison his food. His stable mates have moved away and the staff has stopped trying to reassure him or correct his perceptions. He will eat food that his family brings, but when they leave meals for staff to serve him, he again complains of contamination. The patient has history of Alzheimer's disease. So the patient is already a dementia patient. Okay. His family describes him as having always been overly cautious. His suspiciousness toward caregivers rather than Alzheimer's disease per se necessitated his move to long-term care. The family asked about risk and benefits of initiating medical therapy to address his behavior. Examination, the patient has lost about 1.8 kilos in the last 2 months. BMI is now 20 kilos per meter square. Physical and lab findings do not identify a cause for weight loss. So, which one of the following is true for this patient? 4 options. The first one is a second-generation antipsychotic agent would double his mortality rate compared to placebo. What do you think? Choice B, citalopram at a dose of 40 milligrams would be the best choice for these symptoms. Choice C, control of symptoms with a second-generation antipsychotic agent would carry a higher risk of mortality than the use of first-generation agent. His symptoms justify a use of second-generation antipsychotic agent. What do you think, doctors? The most likely correct answer. A second-generation antipsychotic agent would double his mortality risk. We didn't mention this point. We said that antipsychotic generally will increase all-cause mortality rate. So, unlikely to be the correct answer. SSRI, citalopram effect in this patient with paranoid delusion, unlikely, right? So we have 2 doctors answer D. Okay, let us continue ruling out false answer. Control of symptoms with second-generation antipsychotic agent would carry a higher risk of mortality than the first. No, as I told you, the only information we mentioned is all of antipsychotics will increase all-cause mortality. So what about D? His symptoms justify a use of a second-generation antipsychotic agent. Yes, the patient is experiencing paranoid delusions. We can use a low-dose second-generation antipsychotic cautiously. Yes, you are correct, doctors. As you can see, his symptoms justify use of second-generation antipsychotic agent. Okay, good. For the second case, we have a 70-year-old woman comes to the office to establish care because her previous physician retired. She is a retired nursing supervisor. Her main concern is that for the past year, neighbors have tried to get her to move by purposefully damaging the steps leading to her door. She does not know why her neighbors wish her harm. She produces photographs to illustrate the damage. However, the steps appear to be intact for the physician. Her daughter lives with her, but she has asked the daughter to leave because she believes the daughter damaged the interior steps. The patient says that her daughter has her reason, but she is secretive, cannot be trusted. So you can see the paranoid nature of her delusion. Let us continue. The patient is active in her church and manages her household, shopping, and finances without assistance. So she is dependent. During the interview, the patient, she is independent, like she is functioning well. During the interview, the patient is alert and courteous. She is well dressed. She denies any history of abuse. Laboratory findings from the 6 months ago confirm that she is in good health. she consent to give a cognitive assessment and mentions that her previous physicians also performed an assessment and the result of which were normal. Findings from today's assessment are normal. Which one of the following is most likely diagnosis? So, doctor, as you can see, everything in this lady is normal. Apart from what? Apart from paranoid, apart from her paranoid delusion. What is the diagnosis? Mild frontotemporal dementia, delusional disorder, schizophreniform disorder, paranoid personality disorder. What do you think? Excellent. Most of you doctors got it right. Actually, all of you. Yes, it is a typical scenario for what? For delusional disorder. The patient will be functioning fine, independent, and everything is okay apart from what? From delusion. Okay. Another case, we have 76-year-old man comes to the office because he cannot sleep. He is a retired lawyer, devout, energetic. He serves as a legally appointed guardian, volunteering for less fortunate people. He has become increasingly tense, agitated, and irritable in the last few months. He has displayed volatility in the past. With considerable urging, he confesses that he is certain that the home care companions he hired to care for his court-appointed wards are about to publish pictures on YouTube of him fondling the caregivers. He fears that ensuing embarrassment will taint his family and ruin his relationships with his church. Major depressive disorder complicated by psychosis is diagnosed. So this was the final diagnosis, major depressive disorder with psychotic features. Therapy is initiated with low-dose antipsychotic and antidepressant agent. At follow-up, he seems more agitated than before treatment. After the start of what? Of the antipsychotic and the antidepressant agent. Most likely this physician didn't rule out what? Which one of the following other diagnosis is most likely? Yes, excellent. So what is the diagnosis of this patient, most likely?
It's bipolar 1.
Not delusional, not late onset schizophrenia, major neurocognitive disorder with behavioral disturbance. Yes, excellent. Bipolar 1 disorder. Okay. Thank you, doctors. Do you have any question? Because we are done, alhamdulillah, about the schizophrenia.
Okay, thank you, Dr. Mohammed, for the thorough and interactive presentation. If anyone has any questions, please go ahead.
Thank you, doctors. Thank you. I really appreciate it.
Dr. Mohammed. Thank you. It is great
Thank you, Dr. Nidhal.
presentation. We appreciate. Thank you. Excellent work.
Okay, if no one has any question, we can move on to the next presentation. Dr. Monia, if you're ready, you can start your presentation.
Hello, good afternoon, everyone. My name is Monia Alhadad, and today I will be presenting the topic of polypharmacy in the elderly adult. I'll share the topic with my friend, Dr. Bushra Amer. So let's move on.
Dr. Mohammed, you can stop sharing, and then Dr. Monia can start sharing.
Okay.
Please let me know if you see my screen. Hello?
Yes, not yet. We don't see it.
All right.
Okay, we can see it now.
Okay. Right. So our topic will be polypharmacy in older adults. It's a very important topic that we have to. All right. Sorry, I'm trying to get the label. That's it. If you see it in my screen.
No, you're still on the first slide.
Okay, just yeah. I'm sorry for the inconvenience, but I'm sorry, I have to reshare.
Okay.
Yeah, because I have a problem. There is, I see some black box here. I'd like to move it so you can see the whole. Okay. So I'll start talking about polypharmacy in older adults. Our objectives today at the end of this presentation to be able to describe the key issues in geriatric pharmacotherapy, effects of age on pharmacokinetics and pharmacodynamics, risk factors for adverse drug events for older patients and ways to mitigate them, and principles of prescribing for older patients. And also I'm going to talk about challenges of geriatric pharmacotherapy and age-associated changes in pharmacokinetics and pharmacodynamics, and optimizing prescribing. And Dr. Bushra Amer will talk about adverse drug events, drug-drug and drug disease interactions, principles of prescribing for older adults, non-adherence, and last but not least, the role of pharmacist. As you see in this slide, there is a graph that shows the percentage of different ages. We have here in the this color, like dark orange, represents the people age 65 and over. At the present time, people age 65 and over are they represents 14% of US population. From these people, 33% of them buy prescription drugs. By 2040, the elderly patients more than 65 will increase. They will represent 25% of population, and they will buy 50% of prescription drugs. Okay, so why geriatric pharmacotherapy is challenging? What's the reasons? So we have too many reasons and factors that make pharmacotherapy very challenging and difficult to control. One of them is that more drugs are available each year, and FDA off-label off-label indications are expanding, and also formularies change frequently. And scientific advances in the understanding of drug-drug interactions are increasing. And drugs change from prescription to over-the-counter. As we know now, each year and each month, a lot of drugs move from prescription needed to over-the-counter. For example, most of the hypnotics and allergy medications, pain medications. So it's easier for the population to get it over the counter. This is maximize the challenge. And also nutraceuticals, which are like in the form of herbal preparations, nutritional supplements are booming. So these are the factors that make geriatric pharmacotherapy is very challenging for physicians and pharmacists. So I'll start talking about pharmacokinetics. So pharmacokinetics is what's the drug make to the body? What's the drug makes to the body? Like the action of drugs on body. We have 4 important elements: absorption, distribution, metabolism, and elimination. Okay, I'll start talking about the first element, which is absorption. So aging and absorption. Amount absorbed, which is the bioavailability, is not changed, but absorption may be slowed. Peak serum concentration may be lower and delayed. So the amount absorbed is the same, is fixed or stable, but it's more lower and delayed, the absorption of the drugs. Now we're gonna understand why. We have 3 main factors that affect drug absorption. The first one is route of administration. The second one is what is taken with the drug. I mean, other drugs and comorbid illnesses. As we see, the average elderly patient use daily like from 4 to 5 drugs per day. And as we know, these drug-drug interactions, and if the patient has comorbid illness, geriatric diseases like obesity, hypertension, diabetes, and all the issues with kidney and liver. Factors that affect drug absorption, we have too many elements to talk about. First of all, the divalent cations like calcium, magnesium, and iron can affect absorption of many medications, for example, fluoroquinolones, antibiotics as ciprofloxacin. And the way this patient is, his feedings, if he's like hospitalized inpatient or he's taken parenteral or enteral feedings, also interfere with absorption of some drugs, for example, phenytoin and levothyroxine. And the case of, the gastric pH, some drugs may increase or decrease absorption by high acidity of the stomach. Drugs that affect GI motility can affect absorption. I'll talk about, I pull an example here, that more medications are being formulated into topical products such as gels or transdermal patches. As we know that aging skin atrophies and becomes thinner, and also blood flow decrease to the dermal layer. These factors may alter the systemic absorption from topical products. So these changes decrease the absorption of any topical preparations. So we have to put this in mind. Okay, and we have also the effects of aging on volume of distribution. This is a big topic, but I just put like 3 to 4 slides on this topic to make it easier. So age-associated changes in body composition can alter drug distribution. First, distribution refers to the locations in the body a drug penetrates and the time required for the drug to reach these levels, expressed as volume of distribution or VD. So we have too many factors like body water, lean body mass, fat stores, and also plasma protein as albumin. I'll start talking about body water. So as we age, we know that there is decrease in body water. So there is low volume of distribution for the group of drugs which are hydrophilic drugs, for example, ethanol and lithium. And some drugs, they bind to body muscles. So decreased lean body mass will affect the volume of distribution of those drugs, for example, digoxin. As the body water decrease, in the opposite side, there is increase in the fat stores. So this obviously will be higher volume distribution for lipophilic drugs as diazepam and trazodone. Last thing is a plasma protein. So decrease the plasma protein as albumin as we age because of decrease the function of the liver, the synthetic function of the liver. So will be higher percentage of drug that is unbound, which is in their active form, as ceftriaxone and warfarin and most anticonvulsants, phenytoin, and all the diazepam group. So we have to pay attention to the albumin concentration when we prescribe warfarin and most anticonvulsants, especially warfarin, because most of the elderly patient will be on warfarin in somehow. Now I'll talk about metabolism. We have like two ways of metabolism in the body. One through the liver, which is represent the most common site of drug metabolism, and we have a few medications that metabolize through kidney. So metabolic clearance of drug by the liver may be reduced because aging decreases liver blood flow, size, and mass. So drug clearance is reduced for drugs subject to phase 1 pathways or reactions. We have two pathways of metabolic pathway, phase 1 and phase 2. Phase 1 pathway, which depends on hydroxylation, oxidation, dealkylation, and reduction, which convert drugs to metabolites with less equal or more pharmacological effect than parent compound. Whereas phase 2 pathways through sulfation, acetylation, and methylation, which convert drugs to inactive metabolites that do not accumulate. This is why we prefer drugs that their metabolism are through phase 2 pathway in the elderly adults, because this pathway is not affected by aging. All right, now we come to talk about cytochrome B450. So effects of aging and clinical implication are still being researched. So we have two types of cytochrome B450. The first one is cytochrome P3A4, is involved in more than 50% of drugs on the market. In vivo, age and gender-related reductions in drug clearance have been found for cytochrome P3A4 substrates. For this enzyme induced by a group of drugs like rifampin, phenytoin, and carbamazepine, and in the other way, inhibited by macrolide antibiotics, itraconazole, ketoconazole, and grapefruit juice. So we have to take a good history for of our patients if the patient is consuming a big amount of like grapefruit juice, and also the other co-pharmacy. Cytochrome PD26 is involved in the metabolism of 25% to 30% of marketed medications. It associated with only minimal age-related changes. Cytochrome P2D6 is involved in metabolism of many psychotropic drugs, as Dr. Mohammed mentioned them before, and they can be inhibited by many agents. Some people are poor metabolizers. They refer to PMS. 10% of they represent 10% of Caucasians, and poor metabolizers more than 7 years have serum concentration of 8-fold those of PMS less than 40. So you can imagine the huge difference in the drug accumulations in their body. Other factors that affect drug metabolism, we have age and gender. I'll put an example here, the medication zolpidem. The peak serum concentrations and exposure area under the curve have been reported to be 44.6% and 40.4% greater in older women, respectively, with only modest differences found between older and younger men. So we have to pay attention to the gender of the patient when prescribing this hypnotic. Hepatic congestion from heart failure, for example, leads to reduces metabolism of warfarin. And another factor is smoking. It increases clearance of thiophyllene. Now I'm going to talk about the last element of pharmacokinetics, which is elimination. We have two concepts, the half-life and clearance. Half-life means the time for serum concentration of drug to decline by 50%, and clearance is volume of serum from which the drug is removed per unit of time, like liter per hour or ml per minute. Kidney functions is critical for drug elimination. Most drugs exit the body via the kidney. So reduce elimination, that means drug accumulation and toxicity. Aging and common geriatric disorders can impair kidney function. As we say, as the same things with the liver, like reduced blood supply, size, and function, and also all the other geriatric disorders that can affect the kidney starting from like hypertension, diabetes, and liver diseases. The factors of aging on the kidney, as we said, decreased kidney size, renal blood flow, decreased number of functioning nephrons, and decreased renal tubular secretion. The end result is decreased kidney function. We have an important concept in the elderly adult that serum creatinine does not reflect creatinine clearance, so we don't rely on creatinine. We have so many aspect for this concept. The first one is decrease in lean body mass, so lower creatinine production, and decrease glomerular filtration rate. So the result is in older people, serum concentration stays in normal range, masking any change in creatinine clearance. Okay, we have two ways to solve this, but of course they have some limitations. The ways to determine creatinine clearance through measure and estimate. Measure is time consuming and it requires 24 hours urine collection, which is very inconvenient for patients and for providers. 8-hour collection may be accurate, but is not widely accepted. And estimate is usually done with the Cockcroft-Gault equation. You'll see in the next slide. So the Cockcroft-Gault equation, we have weight in kilogram times 140 minus age divided by 72 times stable serum creatinine in milligram per deciliter. And if the patient is female, we multiply the result by 0.85. It has too many limitations. The first one is in patients without a significant age-related decline in renal function, the equation underestimates creatinine clearance. And in patients with muscle mass reduced beyond normal aging, the equation in the opposite overestimate creatinine clearance. They put some modification of diet in renal disease, MDRD. This is another way to mitigate the creatinine clearance in the elderly, but it's not validated in adults more than equal 70 years old or in a racial or ethnic groups other than white and Black Americans. Now that I talked about pharmacokinetics, we'll move to another aspect of pharmacotherapy, which is pharmacodynamics. So pharmacodynamics, what body does to the drug. Definition of pharmacodynamics is time course and intensity of pharmacological effect of a drug. It may change with aging. For example, benzodiazepines may cause more sedation and poorer psychomotor performance in older adults. The likely cause is reduced clearance of the drug and resultant higher plasma levels, as I mentioned before. Older patients may experience longer pain relief with morphine. Optimizing prescribing. So optimizing prescribing to make a balance between over and under prescribing of beneficial therapies. So we have to use caution with potentially inappropriate medication, PIM. More than 30% of ambulatory older adults receive at least one potentially inappropriate medication. And nearly 4% of office visits and 10% of hospital admissions result in prescription of medications classified as never or rarely appropriate. So this is the fact that we have. Optimizing prescribing, under prescribing can result from the way that most providers think that older adults will not benefit from medications intended as primary or secondary prevention or aggressive treatment of chronic conditions, which is not true most of the time. So we have to pay attention not to over-prescribe, and on the other hand, not to under-prescribe. Because some medications, especially if the patient has diabetes or hypertension, we have some medication, for example, ACE inhibitors used as secondary prevention for kidney function from for kidney injury if the patient is diabetes. So we have to make that balance. Beers criteria, it's intent to improve drug selection and reduce exposure to potentially inappropriate medications in older adults. Recommendations are evidence-based and in 5 categories. We have some drugs to avoid in patients with specific diseases or syndromes, drugs to use with caution, selected drugs whose dose should be adjusted based on kidney function, and selected drug-drug interactions. More information available at geriatriccare.online.org if you would like to know more about this. We have a list here of medications that commonly overprescribed and inappropriately used drugs. For example, we have androgen, testosterone, anti-infective or antibiotic agents, anticholinergic agents, urinary and antispasmodic, antipsychotic, benzos and all the hypnotics, digoxin, and H2 receptor antagonists. There is a big list. And the last thing is vitamins and minerals, as most of the patients, they buy them over the counter. So this is considered overprescription and inappropriately used drugs. On the other hand, we have underprescribed drugs. For example, as I mentioned, the ACE inhibitors for patients with diabetes and proteinuria, herbs, anticoagulants, antihypertensives and diuretics for uncontrolled hypertension, beta blockers for patients after MI or other heart failure, bronchodilators, PPIs for patients who are using NSAID for any reason, and vitamin D and calcium for patients with or at risk for osteoporosis. So we have to pay great attention for not to underprescribe these drugs because they have a very important primary and secondary prevention for most of the geriatric population morbidities. And thank you for listening, everyone. And Dr. Bushra Amer will take over the rest of the presentation. Please let me know if you have any questions.
Hello.
Yes, we can hear you. Go ahead.
Yeah. Good afternoon. My name is Dr. Bushra Amer, and I will continue the same topic that my friend Dr. Monia has started.
Yes, I stopped sharing my screen. You can go ahead.
I will. I'm trying to share my screen. I think I have a problem. Monia, are you still there?
Yes, but we can't see the screen yet.
Yeah. I'm asking if my friend Yumna is still there, so she can share her screen.
Oh, okay, no
Yeah,
problem.
yeah,
So you're gonna
I think
read
I have
from.
yeah, I think I have a problem. So please.
Okay, no problem. Okay. All right, please let me know if you see my screen.
Yes, we can see it.
Okay. All right, go ahead. Sure.
Yeah, there is one slide before the adverse risk effect.
Okay. Right.
It's okay. I will start.
Yeah.
I will start from the adverse drug event. The definition is an injury resulting from the use of drug, and the adverse drug reaction. It's a type of adverse drug event referring to harm directly caused by a drug at usual dosage. The most common type of adverse drug event was an intentional overdose, which almost 67%. Risk factor for adverse drug event. The first one is 6 or more concurrent chronic condition, as we can see mostly in elderly patients. 2, 12 or more doses of drug per day. Number 3, 9 or more medications. And 4, prior adverse drug event. Number 5, low body weight or low body mass index. 6, age 85 or older. And finally, estimated creatinine clearance less than 50 ml per minute. The burden of injuries from medication. As we can see here, the adverse drug events are responsible for 5% to 28% of acute geriatric medical admission. The incidence of adverse drug effect in hospitals is about 26 per 1,000 beds, which is like about 2.6%. Yeah, as we can see here, in nursing home, we spend about they spend about $1.33 on adverse drug event for every $1 spent on medication. Yeah, here the adverse drug event in the ambulatory setting. Adverse drug event rates, it's about 50.1 per 1,000 persons per year. The preventable adverse drug events, about 13.8. Cardiovascular drug, diuretics, NSAID, and hypoglycemic drug, and anticoagulants. Most adverse drug events, about more than 95, are considered predictable. Yeah, here the adverse drug event prescribing cascade. Yeah, as we can see here, the drug 1, adverse drug effect, misinterpreted as a new medical condition. Same thing with the drug 2, the adverse drug event, misinterpreted as a new medical condition.
Excuse me, Dr. Bushra, we cannot hear you clearly if you are using headphones or.
Okay, I will take them off.
Yes, please.
Mm-hmm.
What about now?
Yes, perfect.
Okay. Drug-to-drug interactions. The drug-to-drug action can lead to adverse drug effects. The risk increase as number of medications increase. The most common drugs that lead to drug interaction are cardiovascular and psychotic drugs. Yeah, the most common adverse drug event due to drug-to-drug interaction are first, neuropsychologic, primarily delirium in the elderly. And the second adverse effect is arterial hypertension. The third one are acute kidney injury. Yeah, here we have an examples due to drug interaction. We will start with ACE inhibitor plus potassium sparing diuretic. These both drugs can lead to hyperkalemia. Anticholinergic and anticholinergic, both these lead to cognitive decline. Calcium channel blocker plus erythromycin or clarithromycin, as we know that erythromycin and clarithromycin both inhibitor to cytochrome. This will result in hypotension and shock. Concurrent use of more than 3 CNS active drug, yes, especially in elderly patient, it will result in falls and fracture. Combining digoxin plus erythromycin, clarithromycin, or azithromycin will result in digoxin toxicity. Addition lithium with loop diuretic or ACE inhibitor, yeah, will lead to lithium toxicity. Peripheral alpha-1 blocker plus loop diuretic, these increase the risk of urinary incontinence in women. Phenytoin plus sulfamethoxazole. Monia, can you back to the second page? Yeah, phenytoin plus sulfamethoxazole and trimethoprim, it will lead to increase the phenytoin toxicity. Combining sulfonyl urase plus sulfamethoxazole and trimethoprim, ciprofloxacin, levofloxacin, erythromycin, clarithromycin, azithromycin, and cefalixin, all of these drugs can result in hypoglycemia. Combining tamoxifen and paroxetine, both will lead in increase the breast cancer-related death. Thiophyllene plus ciprofloxacin, leading to thiophyllene toxicity. Trimethoprim alone or as like sulfamethoxazole and trimethoprim combining plus ACE inhibitor or ARB or spironolactone, it will lead to hyperkalemia. Warfarin plus sulfamethoxazole and trimethoprim, ciprofloxacin, levofloxacin, gatilofloxacin, and fluconazole, amoxicillin, cefaloxacin, amiodarone, it will increase the risk of bleeding. And finally, here we have adding warfarin with NSAID. As we know, it will lead to GI bleeding. Common drug disease interaction. Obesity, as we know, it will alter the volume distribution of lipophilic drugs. Ascites alters the volume distribution of hydrophilic drugs. And we have the dementia may increase the sensitivity, induce paradoxical reaction to drugs with CNS or anticholinergic activity. And last point, we have renal or hepatic impairment may impair detoxification and excretion of drug, as we will see in the cases. Role of the pharmacist. The pharmacist has a big role in preventing drug-to-drug interaction through pharmacists who are board certified in geriatric pharmacy carry a designation for BCGB. Practice in variety of settings, including nursing home, hospitals, community pharmacists, and private practice. Assist in designing appropriate medication regimen, including choice of medication, dose, dosage form, and monitoring parameters. Provide information on adverse event and drug interaction, assess adherence, and advise about cost issue. And the last thing, any patient has a problem, he can go to the website so he can read more about the list of pharmacists. Principle of prescription for older patient. Yeah, first, any elder patient, we have to start with low dose. And the second point is titrate upward slowly as the tolerated by patient. And the final point is avoid starting 2 drugs at the same time. Before prescription any new drug, we have to consider these main points. 1, is the medication necessary? 2, what are the therapeutic endpoints? 3, do the benefit outweighs the risk? 3, is it used to treat effect of another drug? 4, could one drug be used to treat 2 conditions? 5, could it interact with disease other drug? And 5, does patient know what it is for, how to take it, and what adverse drug event to look for? Principles of prescription. We have to do this point at least 1 annually. The first point is ask the patient to bring all medication during his visit. This includes prescribed medication, over-the-counter medication, and the supplement for review. The second point is medication reconciliation should occur at each transition of care. The third point is ask about side effect and screen for drug and drug interaction, disease interaction. Fourth point, look for duplicate therapies or pharmacologic effect. The last point, eliminate and remove any unnecessary medication and simplify the dosing regimen for patients. Non-adherence. Non-adherence may be as high as like 50% among elder patients. What are the predictors of non-adherence? The most common predictor is a symptomatic disease. Like any patient, he doesn't have like symptoms, he will not adhere to his medication. The other like predictors are inadequate follow-up, patient's lack of insight or value of treatment, missed appointment, transportation difficulties, low literacy, complicated dosing regime. That's why I mentioned before, it's very important to simplify the dosing regime for patients. And the last point is the poor provider-patient relationship. Non-adherence, how we can improve drug adherence through these strategies. Number 1, medication review and counseling to identify barriers, simplify regimes, and provide education. 2, telephone call reminder. 3, reminder chart and calendar have been shown to be less effective. 4, interactive technology such as automatic pills dispenser to supervise, remind, and monitor drug adherence. Number 5, involve a caregiver. And finally, utilize a weekly pill box or blister bags. Choosing any drug for patient wisely. Don't prescribe any medication without conducting drug regimen review. The summary for all what we have discussed before is appropriate prescription means choosing the correct dosing of correct drug for condition and individual patient. Age, alteral pharmacokinetic, which is drug absorption, distribution, metabolism, and elimination. Adverse drug events are common, but can be minimized with strict attention to risk factor, drug-drug interaction, and drug-disease interactions. And now we will like discuss cases, so we can like provide quick review for what we have discussed, me and Dr. Monia. The first case is an 28-year-old woman come to the office for her annual visit. She says that she is tired of taking so many medications and asks whether she can stop taking any. Her current history, she has heart failure with reduced ejection fraction, ischemic heart disease, hyperlipidemia, hypertension, hypothyroidism, and osteoporosis. The medication that she takes, amlodipine, enalapril, furosemide, vitamin D, levofloxacin, metoprolol, extended release, and rosuvastatin. Upon her examination was normal, which includes her blood pressure was normal and over the 6 months within the normal range. Heart rate also normal, and the estimated creatinine clearance is 50 milli per minute. So the question is, which one of the following medication can be safely discontinued at this time? Anyone know the answer for this question? Okay, the answer is A, which amlodipine. As we can, as I mentioned, for this patient, yeah, her condition, her blood pressure was within the normal range. Maybe before she had hypertension, but now since 6 months ago, his hypertension was controlled and her blood pressure within normal range. So we don't need any more amlodipine. But for the other drug, metoprolol, enalapril, furosemide, we cannot discontinue any one of this as she has ischemic heart disease and heart failure with a reduced ejection fraction. Or this drug are important to reduce the mortality for patients with heart failure. Yeah, the second case we have, an 82-year-old woman is in the hospital because she has surgical repair of hip fracture 3 days ago. After she fell in the bathtub at home, she is dizzy and groggy and nurse notes excessive daytime sedation. Her history, she has hypertension, osteoarthritis, hypercholesteremia, neuropathic pain. Herpes-like medication, which restarted 1 day after surgery, lisinopril, simvastatin, tramadol, amlodipine, gabapentin, and calcium carbonate. Additional medication added during her hospitalization are enoxaparin, oxycodone, docosate, omeprazole, and sina. Her examination showed high blood pressure, which is 150/76. Her estimated creatinine clearance during her hospitalization is 28 ml per minute. And the estimated creatinine clearance 1 month ago was within the normal range, 50 ml per minute. The question is, reduced clearance of which of the following drugs is the most likely cause of her new symptoms? Yeah, as I mentioned before, her new symptoms, she was dizzy and she was sedated. So which the drug is responsible for her new symptom? Is it gabapentin, oxycodone, omeprazole, and enoxaparin? The answer is gabapentin. As this patient, as we mentioned before, that her estimated creatinine clearance was decreased. It was 50, and now during her hospitalization is 28. Gabapentin mainly cleared and eliminated through kidney. So her kidney, now she has kidney injury. That's why the gabapentin increase in the serum, which lead to toxicity. The symptoms due to gabapentin toxicity, as the patient presented, it's somnolence, sedation, and dizziness. Okay. Yeah, case number 3. Yeah, the last case that we have today, it's 68-year-old man comes to the ER because he is dizzy and he had abdominal pain and black stool for 1 day. He lives alone. The neighbor found him and they check him on daily. He has an episode of food poisoning 3 days ago with multiple bouts of vomiting and diarrhea. For this bouts, he takes bismuth salicylate 2 to 3 times daily. He has a history of anemia, atrial fibrillation, and hypertension. His current medication are dabigatran, fosinopril, hydrochlorothiazide, ferrous sulfate, and daily multivitamin. His examination, he has his blood pressure 110/68 and heart rate 104 and respiration 18. His lab findings show like he anemic as his hemoglobin 9, his hematocrit 28 and platelet within the normal range. His blood urea nitrogen 28 and serum creatinine 1.9, the baseline 1.4. Estimated creatinine clearance 22 ml per minute. His baseline creatinine clearance was 58 ml per minute. So the question is, which of the following is the most likely cause of his presenting symptoms? Dabigatran overdose, drug interaction between dabigatran and bismuth subsalicylate and salicylate overdose from bismuth subsalicylate, drug interaction between hydrochlorothiazide and bismuth subsalicylate. The answer is, as we mentioned before, the patient presented with black stool, which mean GI bleeding. This is due to dabigatran overdose. Yeah, the patient has episodes of vomiting and diarrhea. All of this leads to acute kidney injury. As we noticed that his creatinine clearance decreased. His creatinine clearance now, it was 22 as comparing to the baseline 58. And the dabigatran is mainly eliminated through kidney. So increase the dabigatran in serum lead to increase the GI bleeding, which can be reversed through idarucizumab, and like just observe the patient for the next few days. And this was the last case that we have today, and thanks for listening.
Okay, thank you, doctors, for the presentation. I think you've given us very valuable information, especially for people who've been working clinically. These are very important points to consider. Does anyone have any questions?
Excellent presentation again. Thank you. Good job. These are very important topics for the all the physicians when you are dealing with all the adults. You think about when you prescribe any medication, as mentioned before. So you want to avoid side effects and you want to avoid drug-drug or drug-disease interaction. Actually, in fact, when I teach my medical students, I ask them, when you are asked any question about any geriatric patient, your first answer will be this caused by drug. So medication is the first answer for all questions in general in geriatric. So if the patient comes to the hospital with falls, you think about medications. If they have any kidney problems or any heart disease, you think about medication. So first step to rule out the cause related to medication, and then you think about what other causes. So if there is nothing to go home, as a message from today's talk is that medication is important in all the others. So think about it. Thank you so much for the presenters.
Thank you again, Dr. Monia and Dr. Bushra. If no one has any questions, then we can move on to the third presentation. Dr. Nidhal will be presenting selection bias. If you're ready, you can share your screen.
Yeah. Okay, good afternoon, everybody, and happy Eid also. Could you hear me clearly?
Yes, we can hear you.
Yeah, okay, I will share. Okay, I will start now. My name is Nidhal Sadiq. I will present selection bias. I will talk about many things before starting the selection bias. Just I will talk briefly about what is bias and what's type, and how to prevent bias, especially selection bias and what is types. And also at last, we will do some recap about selection bias. So what do we mean by bias? Like, what do we mean by saying bias? Bias is a term used to describe statistics that do not provide an accurate representation of the population. So we all know that all our studies aim to just represent or reflect the general population, all our studies. So if there is any problem in this reflection or this representation, we call this bias. And according to how the process of how this bias occur, then the types of bias will come. So this is the types of bias. Just before saying them quickly, I wanna alert you that when you go on search for the types of bias, you will find a lot of different classification of the research bias. I found in some references they are just putting them as this, and in other references they are just putting them mainly into two categories, which are selection bias and information bias, and all these come under those two categories. In another references, they put in them according to the affection of the bias itself, like how this study will be affected by recruiting, in which there is a selection bias, and if the affection on the interpreting results, in which there is a compounding or lead time bias or length time bias, or if there is the affection mainly upon the performance study, we find that there is a recall, a measurement, procedure, observer expectancy bias. So there is no fixed classification for the bias. But just I wanted you to know that there is a lot of biases and a lot of research bias, and selection bias is just one of them. Okay, so what is selection bias? What do we mean by selection bias? From the name, when we say selection bias, this means that the bias came from the selection, our selection. This means when we select our subjects or the samples upon which we are going to conduct the study, we find that these samples will not represent our target population. So that's why the selection bias came. So selection bias occurs when the selection of the subject in the study or the likelihood of remaining in the study leads to results that is systematically different for the target population. But what do we call this in bias stat? Does anybody of you know when the subject or the study, our study, does not reflect or it will not lead to the generalizability of the general population? What do we call this? It's a question for you. So I would say we call it external validity. So this means that if selection bias will reduce the external validity. And also selection bias occurs in observational study, non-randomized studies such as cohort study, case control, cross-sectional study, but it may also occur in other interventional studies or clinical trials due to poor randomization. Just keep in your mind that poor randomization is the main issue which will lead to our selection bias. So selection bias, when we think about it, it is an error of our study. It's a systemic error, lead to affection of the systemic difference between the participant and non-participant, or between the treatment and the control groups, and can limit your ability to compare the groups and arrive at unbiased conclusion. And this will lead us to another affection of the selection bias. By meaning, let's say we have exposure. We have the exposure or our cases or our subjects, and we will do our study to reach the outcome. So when we reach the outcomes, we will know what's the relationship between this exposure and the outcome, and how this exposure will affect the outcome. So this will be affected if you have a selection bias. So what is this also? We call this internal validity. So also the selection bias will reduce the external validity as well as the internal validity. Okay, so how could we prevent bias? Before going to this, I want to just tell you an example of the selection bias. Let's say to keep ourselves away from selection bias, we should just choose a subject in which there is no difference from the target population. Like we all know that there is a lot of risk factors and a lot of differences, like age, like race, like socioeconomic status. So when we choose our subject, let's put in our considerations that the subject should be include same age, same same socioeconomic status, same race, like that. We will not lead to selection bias. So we found that the most important method in which we can guard against the selection bias is randomization. What do we mean by randomization? Randomization is just like we have a lot of, let's say, in our computer, we have the data of all the population in a specific place. Let's say, for example, Michigan. We have in this computer the population, all of data of the population in Michigan. And when I'm going to conduct this study, I want to, let's say 100 people, and I will let just the computer, or I will pick them randomly without looking at them. So this is the randomization. So like this, I will be sure that those people who are already picked or the computer picked are all have the same characteristics and the same, all have the same features of the general population. That's why they will be a proper reflection of the or representation of the whole population. That's why randomization is the proper method to guard against the selection bias. But we found that also after we did the randomization, it's still we have a problem. Like maybe after the randomization, it's still we can the selection bias can arise. How? Like let's say we have what we call it sampling bias. Let's say we have just chosen those 100 people, and after we are just collecting the data of those people, we couldn't read them. Like for example, when we are calling them, nobody picks the call. Or when we are sending them an email to fill the survey, nobody even, or some people of them do not even check their emails. And like that, you will just lose those people. Or let's say we just chose to do our surveys or call those people at evening time. But then some people have evening shifts, so we lose these people. That's why the sampling bias may arise, and also there is some bias may arise even if we did some randomization. And even the sampling bias is mainly when we choose a specific group, as we said, rather than choose randomly subjects who will represent our target population. So the sampling bias is sampling or a certain bias occurs when some members of the intended population are less likely to be included than others. As a result, the sample is not representative of the population, as we said. And also, there is a low chance to reach those people, which will affect our subjects or our sample. Okay. There is another type, the second type of selection bias we call non-response bias. Usually, from its name, it's obvious what it is. Those people who will fill our surveys or our questionnaires are not responding to it. We usually find that this bias associated with the studies which we need time or effort, so that people will feel that they will not be able to just consume their time in filling the surveys or took some of their effort to fill the surveys. That's why there is something arise, like some researchers try to use incentives, like they give them money or they give them some free food to just encourage them to fill the surveys. So a non-response bias is observed when people who don't respond to a survey are different in significant ways from those who don't. A non-respondent may be unwilling to unable to participate into their accurate representation in the study. Okay. We found that mainly non-response bias and sampling bias, we see that they mainly affect the generalizability or the representation to the general population, or as we said, it's called the external validity. But we find also there is another type of selection bias which will affect the internal validity or the study quality. What do we mean by that? Before we start reading them, I will just tell you briefly about this. Like by example, let's say we just let's say we are studying the relationship between the smoking or the prevalence, let's say the prevalence of lung cancer in a specific population. And the researcher go and took the study group from a home or elderly home or home, let's say home care or retired home, and he came and took the control from young people. for sure the result will not be right, because when the results come back, we will not know like if this result is due to age, because elder age is associated with cancer, or just because of smoking. We don't know that. That's why we call this internal validity affection, or study quality. There is affection of the quality. Okay. Mainly when we say internal validity, there is reducing internal validity. We will mean by that there is inaccurate in reflection of the relationship between the exposure and the outcome. Or internal validity usually means the causation, like what causes. Okay. So the first one of the selection bias that will reduce the internal validity is the health worker effect. What do we mean by health worker effect? It means like when we choose our subjects, we will just go to people who are working. Like this, that researcher go and just pick his subject from the factory, or let's say from any place. Just they are health workers, and we know that the people who are working are fit, they are healthy, and the other people who are at home, he took his control, let's say, from the home, from the houses, or the people who are not working, and we know that those people like are not in a good health. If they are in a good health, then for sure they will go and work. So this, we call it healthy worker effect. Like for example, we will find that the smoking, let's say that the prevalence of lung cancer, or the prevalence of specific cancer in those healthy people is very low. This will not be a reflection of the whole or representation of the whole population, because for sure those people in a good health and those people are fit. That's why we call this healthy worker effect. So another one of selection bias, we call this Bergson bias. The Bergson bias, and that researcher chose his subject from the hospital. He didn't go outside of the hospital. Let's say he studied the relationship between the the diabetes and obesity. So he took our subject from the hospital. So he will definitely find his control filled of smoke, filled of obese people. Because even if they do not have diabetes, for sure there is a lot of other diseases which end up by hospital admissions have already obesity. So that's why this will not be accurate. Okay. And also there is another type of selection bias, called it attrition bias. Attrition bias is in which attrition bias, it has another name. We call it also loss to follow up. Like suddenly we were doing we started the study and we are going very well in this study, and suddenly some people either die or drop out, or we couldn't reach them. This attrition bias occurs when the participants who drop out of the study are systematically different from those who remain. But the problem is that, what if those people who drop out actually develop the disease? Like, let's say we are studying the smoking and lung cancer, and we found that we started by, let's say, 40 people for exposure and 40 people for control. And we find that, like, from these 40 people, 20 of them just dropped out. So that our result will be just from those 20, but we started with 40. Just let's say from this 20 people, just 10 of them got cancer. So this means that 1/4 is the ratio, or 25% will get the cancer. So this is not real. This is not real result because of the dropout, because maybe all those 20 people who we dropped or who we lost, all of them developed cancer, but we couldn't treat them and we couldn't include them in our study. Okay. So I think this is the main things about the selection bias and its types. And finally, we will do just a rapid recap about what we said. We said selection bias. It's mainly the affection due to selection, in which the participant, while we select the participant or the subject, we find that they do not represent the general population, and we said we need to increase external validity and decrease internal validity. External validity means the generalized ability. that's just because the samples, and there is a difference, there is not a similarity, and also because decreased by, we said by two main, with sampling bias and non-response bias. Once the internal validity also decreased, and we said the internal validity decreased by means that there is inaccurate relationship between the exposure and the outcome, which means there is affection of reaching the causation of that specific study or that specific thing we are studying on. We are studying it. So we said which biases affected the internal validity, health workers effect, and person bias, and loss of follow-up, which is attrition bias. Okay, that's all for selection bias. Does anybody have any question?
Thank you once again. Thank you so much. This is excellent short presentation, concise and important points. Thank you so much, Dr. Nidhal.
Thank you, Dr. Nadia.
Thank
Any
you, Dr. Nidhal. Any questions? Okay, I think this brings us to the end of the presentations for today. Does anyone have any project update or anything they would like to discuss?
Actually, I'll just jump in if you don't mind.
Yes, sure.
We want to talk a little bit about database or how they do big studies. So I'm going to share a screen and so I'm going to take the study that's done in Framingham, the one in near Boston. It's a very well-known study for heart disease or the risk for heart disease, the coronary artery disease. This study was done since 1940 or something. This is just how I prepared the slides for you guys. So I'm gonna show you two different things. One, when I ask you to present, you do what the blue team just did. So any presenter can select a topic, and then they can divide that, or they can do it by themselves. So one presenter or two or more presenters can share the slides and then talk about each section of the topic. So I want to give you an opportunity so that you can practice and improve your skills of presentation. Sometimes you might have obligations, so I understand that you might not be able to participate, but think about it as an opportunity for you to improve for each member of each team in this program. So one of the ways you can do is you can look up the topic. So what I did here, I talked or I searched using Google search about the topic. If you don't have the slides, we have some teaching slides already made, as mentioned in the first two topics. So you have the files ready, you just practice and then present to us. If you don't have the slides ready, you can find some resources for you, or sometimes you can find some already made slides. For example, this, I'm going to talk about Framingham Heart Disease or Heart Study about walking. There is no specific point about walking, but the topic can be found in different slide sharing websites. So if you go to this, for example, you can find at University of Massachusetts, they already have some slides done. So you can borrow some of the slides there. You just download the PowerPoint slides, and PPT stands for PowerPoint slides. So you can download and then see if this is good slides for you to present. If not, then you go to the next or the next. And when you have the slides that are ready for you, you can use them. There are different websites like SlideShare. they have free versions. So you will have the topic, and on the right side, you might have some other similar topics that you might find interesting or related to the topic. So you can combine some of the slides from different topics if you want to present. So for example, this is extensive slide presentation, 76 slides. So we don't want you to present the whole thing. You can summarize some of these slides for us. Usually it's 15 to 20 minutes talk. So maybe 25, 30 slides out of this. So maybe half the slides. If it's not relevant to the topic that you want to present, maybe some other slides here you can find on the right side that might be useful for you. So another way is to create your own. And in this program, I want you to learn how to use the artificial intelligence. So here I'm using chat.openai.com, which is ChatGPT. So I asked the ChatGPT about this study. Can you outline? So this is a prompt, or can you help me get information about this study? So I asked the ChatGPT to list the point in an outline format. So this is what it found and put it for me in a point selection, like 6 or 7 points, that 5 points that I can talk about. So when I have my material, I can then go in depth. I can ask the artificial intelligence to elaborate for each point. So here I found that the machine added more information for each of the point, the background, the purpose, and then the study design, and the key point out of this design, and what the data collection, and then the impact of the significance and the effect out of these studies. It's a long study. Many years people collected all this information, so we can benefit from it. So what I did again, I asked the ChatGPT to create slides out of this information for me so that I can present for you guys. So it created slide 1, the topic or the title, then it created the background topic and so forth. Slide 2, more or less in a point, bullet kind of approach, summarizing the topics or the point that I want to talk about. One more thing I can ask her, can you add speaker notes? So now it will, for each slide, it can add the speaker notes so that I can elaborate in each bullet point, and I can add this when I'm presenting to you guys. I can talk out of these bullet points. So this is one way to create, and you can sometimes stop in the middle. You can continue generating, so it will finish all the slides for you. So for each slides, it will give you the points and then the speaker notes, and you can add that to PowerPoint slides. What I did is I'm gonna just copy, and to copy that, you just click here. I copied it and put it in a document, a new document in Google Docs.neo. It will create a document, and I just paste the information there. I edit it, just it has like a dash here. I just remove that. So now I have all the main points for each slides listed here. There is an extension that I'm gonna use. It's converting the document, this file, to a slide file. So I'm gonna show the slide on this side. And then I'm gonna create slide in Google. So I go create the slides, and hopefully it will create the slides for me. So the first slide might be just a blank one. I can delete that, but the second slide will have the title, then the background, and then for each, it can incorporate all this information for me so that I can present to you guys. So this is one way to create the slides for your topic. If you want to know where did they do this study, it's near Boston. So I lived in Boston for 4 years, and I know the place. So it's a suburb of Boston. So this Boston area, Framingham, it's somewhere west to the Boston area. So we used to go and visit friends in that area. So what they did is they collected information from patients or from healthy people, and then they continued to collect the information and see if they are still healthy or if they develop any kind of medical problems related to the heart disease, if they have coronary artery disease. And what they found, the key findings of this study, is that high blood pressure is related or is a high risk for coronary artery disease, high cholesterol, as well as smoking, diabetes, obesity, and physical inactivity. So this is the main findings, but they have found other things that they created a tool. It's called Framingham Risk Score tool. So this can be used to estimate 10-year risk of cardiovascular disease. So you put the data of the patient in this tool, and then it will give you the risk factor or the estimated 10-year risk of cardiovascular disease. It has its own limitation, so we can talk about that in details, but they focused only on the coronary artery disease. They didn't get information of, let's say, heart disease, like heart failure and so forth. It's a very useful study. So they created some guidelines out of it. And most of these guidelines now are used by the association like the American Cardiology group. So you will find this as recommendations, and it can be seen also on some of the board exams. So just this is a summary of what they did, and hopefully this will help you understand some of the concept of the guidelines or the recommendations. When you practice, you will find some of this recommendation coming from similar studies. So this is how they did it. There are different ways and different methods. So it's a long topic. I just want you to know that every one of you can present any topic. If we have the slides ready for you, that makes life easy. If you want to add more information or update the slides, that's also an improvement that you can do. If you want and you don't have the slides, you can create your own slides. And I showed you the method to do that. There are different methods, but this is one of them. You can search through Google. You can use artificial intelligence to do that. So, and again, you can work in teams. So the presenter can be a single presenter, or the presenters can be 2 or more for the one topic, so that you can divide the task between you guys. And at the same time, you will get the credit. So in your applications, let's say you apply for ERAS, you will mention that I presented 3 topics to the fellows in this program. So it indicates that you have the skills of presentation, you are confident, you are improving, you are not staying without doing anything useful. So you are teaching, you are learning some methods of teaching. Some of the teaching slides might be you just read, you can convert it into an interactive session. Some of you in the past did that. I think one of the cardiology about the EKG in the past, they used some interactive, so you can ask the audience their input and what they think about what they practice, because we are different in different places. So in UK, we do things different than in the US or in the Gulf area, for example. So you can elaborate on that and get some input from the audience as well. So just I want to share with you. All right, so we have Dr. Rufaida. Please jump in. Thank you.
Hello, Dr. Nader. Hello.
Hello. Please go ahead. If you are ready to present, that would be great.
Now? You mean now?
I
I
thought you
was
are
just
talking about
asking,
now.
like, I mean, okay.
No,
So,
if you want, or if you want some other time, that would be great.
okay. So I have some abstracts that I actually worked in, and I felt like I want to share it with you guys. So if that's okay. I mean, like in the future, like to make it in a PowerPoint and then to share it with you guys. If that's okay.
That would be great. Yes.
All right. All right. Thank you very much.
No problem. Thank you. Thanks for your contribution.
Thank you.
Other questions or any other comments?
Hello, Dr. Nadir. This is Magdas. How are you guys?
Very good.
Anybody from the team leaders, so that we would know, let us know the schedules ahead of week. Is there any schedule that's booked presentations for next week?
So I'm gonna share with you. We have the app itself. If you go to the application, you will have when you go to the main page, you can go down to the upcoming Zoom meeting, and we divide it into teams. So the blue team was presenting for today, then the green team will present for next week, and they have their team leader and then moderator, or they will add these are the topics we suggest for next week. So we have some slides ready and some are not, so people can bring their own material. And so when you talk to your team leader, they can, in the future, we will add their schedule somewhere here so that you can present, if that makes sense.
All right, I understand. Thank you, Dr. Nadir. I was hoping I could be in touch with the other team leaders. That was my question too, yeah.
Sure. So let's say you are free for next week, and you can reach out to the green team leader and see if there are opportunities for you to participate with that team. For example, most of the team are in Sudan and they have problems, let's say, with what's going on there. And the other members here in the US, but they are preparing for step 3 or they have other obligations. So we don't have enough people to present for next week, let's say from the green team. So the team leader will say, hey, we need some help. So if you are available, we can contribute to take one of these topics and then you can present. This is what we do. So the organization for teams is just to be efficient and effective as teams and make opportunities available to all of you guys, hopefully equally. But I understand some of you might have other obligations. As I said, some might be preparing for the steps or doing exams or traveling, so they are not able to participate or present. So it's easier to communicate with the team leader, telling them, hey, I can't do this. Can you find someone else? So they can find from the team people to present, or they can ask other team members from other teams to jump in and participate.
Thank you very much, Dr. Nadir. And Maysam is reaching out. So yeah, I actually got the information. Thank you very much, guys.
You're welcome. Thank you. Any other updates or any other questions, comments?
Hello, Dr. Nader.
Hello, go ahead.
I would like to share we successfully submitted our manuscript to the Journal of American
Sorry,
Geriatrics.
Dr. Asma, your voice is kind of in and out. It's a little bit hard to. Can you bring the mic closer. Go ahead.
Is it better now? Awesome. So I just wanted to share that we successfully submitted our manuscript to the American Geriatric Society. And now we are looking for conferences that we can submit our abstract to. So I just want to share that.
Excellent, excellent. So you submit it as a paper, right, for the journal?
Yes, a manuscript, yeah.
Congratulations, that's good. So it's gonna be reviewed, and then they're gonna give you a feedback. Either they are accepting it right away, or they are considering accepting it with some modifications, like some editing or minor edits. So you make these changes according to what they highlight, and then you resubmit it to them. Then they will accept it, or sometimes they will reject, and sometimes they will give you the reason for rejection. Let's say in this journal, we don't cover this topic, for example, something like that. But hopefully you will hear good news, and hopefully it will go right away for acceptance.
Yeah,
Regarding the poster, are you going to work on the same topic or different topics to submit posters?
So we wanted to actually submit this one for, we're looking for a conference now that is focusing on disabilities and older adults. So we're still in the session, step.
Excellent. Good.
Thank
Good luck.
you.
Thank you for the update.
Thank you.
Any other updates?
I would like to share that our team has completed the first stage of screening of the articles to include in our systematic review. And then hopefully we're moving on to the second stage of screening and then data extraction. So hopefully maybe next week we'll have at least part of the manuscript ready, inshallah.
Inshallah. Good. Good job. Let me know if I can be of help. Excellent. Anyone else?
Hello, Dr. Nader.
Hello. Go ahead.
The team for the systematic review, the neurocognitive implications of COVID-19, we have already finished the data extraction. We're on the stage of data analysis, and we're hoping to also have our manuscript written within the coming days.
Excellent.
All right. Thank you.
Thanks for the update. Yeah, excellent. Thank you.
Thank you.
I know in July and in August, some of these conferences also, they have the deadline for submission. So if you are thinking of writing some of the abstracts, let me know so that we can work on it fast so that we can meet the deadlines, guys.
Yes, there is the conference in Washington. I think the deadline is in the 21st of this month. So we're hoping to be able to submit our abstract to that conference. So when we're by the time we're going to finish the analysis and start writing the abstract, we're going to send it to you, inshallah. Thank you.
Thank you. Any other comments, any other updates or questions? If none, then I know one team is going to present, I think, next week in the Alzheimer Association meeting virtually. So I wish them all the best. And let me know if I can be of help, guys. Thank you so much, Dr. Mason. Oh, Dr. Nada, go ahead.
Hi, Dr. Nader. Hope you're doing well. I hope everyone's doing well. I just had a few ideas that I shared with my team leaders regarding new systemic reviews, and they have approved some of them, and I'm working on them. Would it be okay to send you an email once I have certain ideas to present to you?
Oh, sure. Yeah, definitely.
Okay. Sounds good. Thank you so much.
You're welcome. Good luck.
Thank you.
Thanks. Thanks for the update.
You're welcome.
Thank you. Samia, Dr. Samuel Ajab. Go ahead.
Hello, everyone. Hi, Dr. Nadia. I have a different question. Actually, it's not related to this. I'm just asking regarding the ChatGPT. Do you recommend using it for like modifying our personal statement, like after writing it, or what do you think about that? Would this consider something illegal to be done?
So what I'm using it so far is I'm using it as a reviewer. So I can use it as, in the past, we used like word spelling check, for example. So I'm gonna use it. So you write your personal statement and you give it section by section, let's say, or paragraph by paragraph, and see what correction they can make or what suggestion. And then you can accept or reject whatever they suggest for you as improvement. Because the language, for example, my English is not the first language for me. So I can write things in English, but for the English speaker might not be the right thing. Although grammatically and spelling check, everything is correct, but sometimes it doesn't cross to people the way I want it, if that makes sense. So when I write it, I will get some input or some suggestion from ChatGPT and see if they correct some of these things for me, then I will accept their correction. I'm gonna show you, let's say, gonna share the screen with you guys. So let's say if they can find something about so let's say he's gonna give me a summary of the telegeriatric research fellowship. So I'm gonna take one paragraph of my personal statement. Let's say this is my introduction. I'm gonna ask, can you suggest some improvement, let's say, in the following. So this is what he or the artificial intelligence wrote for me, or this is my actual, let's say, personal statement, the paragraph. So there are 6 or 7 sentences in my paragraph. So it will modify my first sentence according to what they think it's corrected. I can further ask them to repeat it, but this time create a table with the original sentence in column 1. So here it's gonna take the sentence, the original sentence, it will put it on column 1, if it's working right. And then the suggestion in column 2, so what they change and what the reason or why they change it, or what part of the sentence will be listed here. So this is how I use it to improve my let's say if in your case, personal statement. So I'm gonna take part of it, give it to them, and then we'll see if there is any suggestion for improvement and what part of the sentence. And sometimes they explain why. Is it just for the clarification, or maybe they can add a synonym, a better word versus what I wrote, if that makes sense.
Yes, totally makes sense. Thank you so much, Dr. Nader.
You're
Okay.
welcome.
And my second question, if it's okay, is it okay to ask another question?
Oh, sure. Yeah, go ahead.
Okay, so my second question is that now we're looking at programs now, and we see a lot of like making our list. If I like find myself in a program that like I have one thing that I'm not, let's say like year of graduation is they just like had the cutoff, and I'm not meeting that criteria. Do you think I still have to risk it and like apply to that program? It could be any other criteria. Let's say I'm not meeting any one of their criteria, but do I still have to put that, or I just like completely take it off my list? What do you think?
I think there are a couple of things. What I suggest is you try to contact some people inside the program. If you can reach out for, let's say, residents in the program. If you have connections, that would be great to see how the program is dealing with these criteria. Are they rigid? That means 5 means 5, and they don't have exceptions, or are they flexible? They say 5, but sometimes they may have good candidate that, let's say, 6 or 7 years or something, so they can accommodate for that. They are flexible. If they do, then yes. If you can't find out, I think the best thing is to stick with what they say. And if you don't meet the criteria, don't waste your time and money. This is my suggestion. If you want to try, I have no problem. You can try, but it's better to try in a program that they don't have rejection criteria or exclusion criteria for you guys. The best thing is to increase your connections. So most of the program, they will have some people who suggest or recommend some applicant from outside. And if you find some of the connection that they can pass your application or information to the program or program director, they can at least think about you and say, oh yeah, or they can say, no, although she's a good one or he's a good one, but our program doesn't accept. So at least you will find out something before you apply or send your money, if that makes sense.
Yes, thank you so much. I appreciate it.
You're welcome, and good luck. Go ahead, Sarah.
Hi, Dr. Nader. Hello, everyone. To be honest, I just wanted to comment on the question of the chat GPT, if you allow me.
Oh, yes,
I worked in a reviewing motivational letters in some things related to universities, and I had some comments from friends that work in some embassies. It's just like something I need people to take care of. When you give any AI to write you anything, you have to make sure that you humanize what they wrote after writing it. For an example, you want to make the chat GPT write for you something related to an application or something personal. Make sure after the message is written, you humanize what's written. Because nowadays, especially in embassies and in big programs, there is a problem happened that one student applied for a scholarship and he got accepted in the scholarship based on a motivational letter, which was written by an AI. So they did modify this by getting to know the things written by an AI. So if you have an application and you apply to using an AI, they might come to know based on some sentences or some words used in the AI system. So whenever, if it's chat GPT or whatsoever, just after making it, after it's written, make sure to take it, and there is some apps that you put this in it and ask it to humanize it. It will remove the word that they can find out that this was written by an AI. And again, do not let an AI write a whole thing. it's better it's used as a reviewer, as Dr. Nader just mentioned, or for a grammatic checking. But if you decided to make the whole thing be written by an AI, make sure to humanize it. That's it.
Excellent. Thank you so much for the addition. Yeah, so what Dr. Sarah mentioned is that when you use AI, make sure when you use it, either you can communicate that to the identity or institution that you are using AI, and you are not depending on the AI to write everything for you. And the other reason is because some of the institutions or some of the identities that you are submitting your work to them, they have the ability to recognize which part, or if at all your written text are made or written by an AI. As there is an AI tool to help you or write, there are other tools that they can, it's like the antigen and the antibody. There are some tools that they will recognize some of the text that are written by the AI. It's called AI detection tools. So they can run whatever you, let's say you wrote, you ask the AI to write a whole personal statement and you copy paste that. If you submit it to a program, what they can do, they can copy paste and paste your personal statement into an AI detector tool, and it will show them if this is written by a human or by AI tool, and it will show them, is it 100% AI made, or is it 50% or 25%, something like percentage. What you can do is you personalize, as Dr. Sarah mentioned. So you can take it piece by piece and see what you can modify according to your personal, let's say in your personal statement, your personal story, and then modify it. Sometimes what I use is you can change some of the synonyms, some of the words with a similar word. Sometimes you can just flip-flop. So instead of putting, let's say, both number 1, number 2, you can say number 1 as well as number 2, something like flipping the words. That also can help. So there are ways to humanize, as Dr. Sarah mentioned. So please make sure you use it wisely. Thank you. Dr. Nidhal, go ahead.
I'm just asking, maybe you answered this question previously, but I don't know. Let's say I just chose a research title. From where could I collect my data? Like, from where could I reach subjects' data? If now I'm not at hospital and I'm not practicing medicine, now I could reach any data for the population on whom I will conduct my research.
So it depends on what you want to do, the topic itself, what it is about. Number 2 is your method. So what kind of method you want to do? Is it you want to get information from now on to the future collecting? And this is what they did in Framingham study. They started on whatever, 1948 or some, and then they start collecting for the future. Or in some cases, you want to go back. So it's easier to go back. Some database are there. So there are some inpatient database for the hospital here in the US. The problem is it's not up to date. It's 2 or 3 years behind. So you can look at this data set or databases and collect whatever information you want to collect according to your question. There are some like if you want to, with the new EMR methods, you can collaborate with someone who works in the hospital and then share the idea. So I want to collect the information, this from current patients or past patient hospitalized. Then they can talk to the IT team, and then the IT team can run a query where they look at the database of the hospital instead of manual. In the past, we used to open the chart and then collect all the information from the actual chart. Now, with the IT, they can extract information from the electronic medical record for each patient, depending on your criteria, and then they can collect you or give you the information in an Excel format, let's say Excel file.
So let's say it is retrospective, and we all know that I'm not allowed to read the records of the patient. So I should just, as you said, it's not clear for me. Like, should I just email the doctors and the residents in any hospital and ask them to help me in this, or should I go directly to the hospital and ask them how could I reach your records?
So again, each hospital is different, each program is different. So you want to reach the top of the, let's say you are interested in a topic about geriatrics. So if the hospital has a residency program or has some division for geriatric, so you go ahead, contact the chair in the department or the division for geriatric and mention you are with our fellowship and you are interested in researching some topic about whatever topic, and you need their help and you want to start collaboration with them. So they can assign someone, or they can direct you to someone in their program in the hospital to contact you. And then you already made the connection, then you can discuss about what the next step. So you want to identify the variables that you want to look in the chart. Then the person in the program, they can agree with you, or they can add or remove some of these. And if both of you reach a point where you ready to start, there is one point that you need to understand the IRB approval.
Okay.
Someone need to get an approval if the data is de-identified and it's collected as a condensed data, not individual one by one with identifiable data, then the IRB can approve that faster. So you need the same person or someone from the program or the hospital to apply. And if they approved, then they can talk to the IT and then they collect the information for you.
Okay, it's clear now. Thank you, Dr. Nader.
Any other questions or any other comments? Go ahead, Dr. Nada Ashraf. Your voice is kind of far away. Sorry, still I can't hear you. Can you check your mic, please, and thank you. The other way is to use the chat. If you have trouble with the mic, you can type your question. So Dr. Sarah in the chat mentioned some additional information. So if you want to look at the chat as well, that would be great.
Okay, I'll do that now.
Dr. Nada, we can't hear you. Okay. So Dr. Nada was asking about the systematic review. So the best way to do the systematic review is to work in teams. So if you know how to do it, that would be great for you, but I suggest that you create a team with the new fellows who don't know how to, and then you can divide the task between the team members so that they can learn the process and they can improve their skills. And it will be less on you as one single person. If you yourself is new to the idea of doing the systematic review, then I would suggest to contact some of the senior fellows or the team leader to guide you through the process. And then you can also create a team, and then the senior and you can work on dividing the task. Then you will work on one part, other fellows will work on different parts or tasks, and then you complete the project. This is what they did in the past. Most of the projects completed by more than one fellow. So Dr. Rofaita will be happy to help you if.
I have one last question, if it's possible, Dr. Nadir. One last suggestion. So since matching application, IRAS application, the season is coming up, I don't know how many fellows are planning to apply this year, but we'd all appreciate if there's one session held about personal statements, general highlights about the matching process, applications, personal statement editing, some other technicalities. Just one session. Anybody who's willing to share the application with us, that would be great. I don't know if anybody have an opinion about this.
I think it's a great idea. We have some samples from previous fellows who matched to residency or fellowship. So they kindly shared their personal statements and their IRAS applications. So people who are interested in applying through IRAS can look at these samples or personal statement applications, IRAS applications, and they can see what they can write or how they can improve their application or their personal statements. So I'm gonna share with you later, or maybe now, the website where you can log in and look at these personal statement and applications.
That would be great, Dr. Nadir. Thank you very much.
Any other comments or questions? So can I share on the chat the website? It's called irasdocs.glideapp.io. So you can log in and see if you want to look at some of the previous personal statements and IRAS applications so that you can maybe improve.
I can see it now. Thank you very much. I think Mason posted it.
Oh, yeah. Thank you so much, Dr. Mason. Any other comments, points, questions, or suggestions, ideas? So if not, then I'd like to thank you so much, Dr. Mason and your team. I'd like to thank all the presenters from today's Zoom meeting and all the attendees. Thank you for your time and thank you for your effort. Great job for everyone. Thank you again, Dr. Mason, for organizing this and moderating this Zoom meeting. I wish you all the best. Hopefully we can see you next week. Thank you. Assalamu alaikum. Happy Eid.
Thank you. Thank you, everyone. Thank you for sharing all
Dr.
the
Nader.
information.
Thank you, Dr. Nader.
Thank you.
Thank you.
Have a good Eid. Assalamu alaikum, everybody.
Assalamu alaikum.